All right, we're up. We'll get started. So welcome, everybody. I'm Mark Rother, Chair of the Department of Medicine. Welcome to the first of the Chairs Grand Rounds for whatever year it is, 2021. Everyone knows my joke. It's the 573rd day of April of 2020. We have a special set of rounds today, and I'd like to thank the Department of Psychiatry and Neurobehavioral Sciences. Nick Cates and his colleagues, who I'll introduce shortly, had asked if people wanted to have a grand rounds on surviving COVID-19 from a psychic perspective, and I thought that was a great idea. There's an awful lot of interest right now in wellness, and I think you'll find this to be a great set of rounds to help us better understand what's going on with COVID-19. We have three presenters today. So Dr. Margaret Mckinnon, I've known for years. Margaret works at St. Joe's and at the Homewood Center in Guelph. She's done a ton of work and is a highly successful scientist in the areas of post-traumatic stress disorder and has, I think, uniquely done a lot of work with the Canadian military. Dr. Tara Riddell completed her MD at Dal and residency McMaster, and was most recently a clinician health and wellbeing fellowship through the University of California. She's an assistant clinical professor at McMaster and a psychiatrist for the addictions medicine program at the Homewood Healthcare Center in Guelph, and has done a lot of work on physician wellness. And Dr. Sabina Nagpal is an assistant professor, a psychiatrist with a public mental health interest, and holds a master's in public health from the London School of Hygiene and Tropical Medicine. She provides clinical psychiatric care at the Women's Health Clinics at St. Joe's Healthcare in Hamilton, and has done a lot of work to mitigate the psychological impact of COVID-19. So as always with grand rounds, the chat function is turned off. So if you have a question, ask it in the open questions box. If there are questions that can be addressed easily during the course of the webinar, we'll do that. So for example, if someone says, I can't hear, I can answer that in the chat and it'll disappear. If someone has a more complicated question or something I think would be of broad interest to everyone, we'll leave it till the end and we'll have a few minutes for questions at the end. And if you're having technical problems, most often that's due to your computer. So probably a good idea is to just restart or change your audio source for both hearing and or speaking. So without further ado, I'll go ahead and let our speakers move ahead with the presentation, and I'll pop back on towards the end. Thank you very much.
Thank you. Good morning, everyone. So as mentioned, I'm Dr. Sabina Nagpal. I'm going to start off with looking at the impact of mental health, the impact of the pandemic on mental health, mostly of physicians. So my disclosures, I sit on the advisory board of a couple of commercial companies, and Spring Resiliency Consulting is my own venture. So our learning objectives for today, I'm hoping by the end of this, you'll have a better understanding of the impact of the pandemic on the mental health of healthcare providers, specifically physicians. Identify the impact of the pandemic on leaders, teams, and the health system as a whole. Look at key resilience factors, including some individual functional domains, and how the work environment can better support physician well-being. And then I'll share a list of resources that I won't go through, but I'll make them available if anyone's interested. So to start off, a couple of polling questions, which are somewhat rhetorical, but number one, physicians can tolerate the stress of the pandemic without increased supports because we're well-trained, compassionate, and chose this line of work. So just have a think on that. Hopefully that gets answered. And the second is the mental health impacts of the pandemic will resolve once the pandemic is over. So what has the impact been on all of us, on physicians? I'm going to start you at the top of this diagram. This diagram could have had about 50 more of these balls, but I just picked a few. But we start from the top. We're starting with physicians already burnt out. If we go back to sort of early 2020, surveys of physician burnout were showing that about 2/3 of physicians were already expressing burnout. And this is before we had COVID come to us. And then if you think back to the early days when the pandemic was more alive in other places and hadn't quite come to Canada, there was a lot of worry, a lot of uncertainty about what it was going to look like when it came here. The risk of infection was real. In the early days, about 1/3 of hospitalized patients in Wuhan were healthcare workers. So there was a real risk of infection, and we didn't know what it was going to look like when it came here. And there was a true risk of infection to ourselves, to our family members. There was challenges with PPE and whether we were going to have PPE. I know many of my colleagues were really struggling in the early days of the pandemic around just simply protecting themselves from the job that they were meant to do. Then you add in, all of the morbidity and the mortality that all of us have seen, especially most of you in the audience who were really, really actually there on the front lines. And the psychological impact of that is huge. I think a lot of us saw our resources, our healthcare resources stretched to the brim, right? Seeing our wards full, needing to open up new wards, and just seeing that our system was sort of busting at the seams and worrying about how much longer our system could sustain this. All this a long while there being delays in vaccine rollouts, and really wondering when the end of this would come. A lot of overload. I heard a lot about overload from the physicians I work with, just feeling like there's no break from the pandemic. And then our own resources being stretched, feeling the need to sort of steal from family time and family needs to give to work needs, and the back and forth of that. Not to mention those of us with young kids and school closures and having increased family needs in the context of work needs. A lot of difficulties around political decisions and feeling like they weren't necessarily in line with the science. A lot of irritability and anger about that, and having trouble kind of sort of accepting that, some loss of faith with that, which I'll get into. More recently, the vaccine hesitancy. Physicians have expressed a lot of difficulty with caring for the unvaccinated and kind of the compassion fatigue that has resulted from that. And then staffing shortages, which are ongoing. And again, this list could go on, but I just wanted to kind of remind ourselves of the journey that we've been through and that we continue to go through. So what is the impact of all of this? I like to approach it using this kind of puzzle of various lenses, starting with kind of what are our normal responses to stress, looking at some of the international data. Most of the international data is more focused on China and other parts, not a whole lot, not as much in Canada. So I like to look at the kind of the local qualitative data. And then we'll just peek at SARS as a glimpse into the future and what the lasting impact of this might be. So what are normal responses to stress? I'll let you read them for yourself, but I've highlighted the ones in blue that I think a lot of our physician colleagues have expressed to be kind of the most, having the most impact on them. And the shorthand for this basically is too much. So feeling over-regulated or over-aroused, difficulty sleeping, feeling jumpy, feeling on edge, irritable, or going the other way, more on the kind of depressive side, feeling flat, feeling like you want to avoid, lack of energy, fatigue, low mood, and substance use is a big concern as stress arises. So all this to say is that even for those of us that started this pandemic at our best, if you will, or not feeling particularly burned out, it'd be quite normal to have some of these experiences, and normal responses to stress are actually quite distressing. So if we look at the international data, this is from 2 systematic reviews, one from last year, one from this year. And the numbers vary, but let's say upwards about 2/3 of healthcare workers are reporting distress. The domains they've looked at are depression, anxiety, stress, and insomnia. The risk increases with nurses over doctors, women over men. Younger medical staff actually have more of the psychological difficulties. Frontline and direct contact, those at the epicenter, those dealing with the sickest of patients, those dealing with the highest workload with less break. Those are the people that are highest risk for these psychological difficulties. Your sleep status, if you have poor sleep, it increases your risk of psychological distress, having an underlying medical condition, also having an underlying psychiatric condition. And then some protective factors. So having PPE, right? So this is international data to some places where that's still a really big issue. And then system support and resilience. Both of those are not that well outlined in these studies, but I'll get into sort of my take on those and looking at other literature to understand that a little bit better. These are some themes from the women physicians I work with. In a group format, I've run a group for women physicians to bolster resilience in COVID, and also on individual level. So this is kind of qualitative data. A lot of difficulties with the uncertainty and the anxiety that stems from that. What if I can't do it? I can't manage. What's coming next? When is this going to be done? Anger and irritability is quite normal in this during the course of this pandemic, feeling that things aren't fair, that no one's actually taking care of us being physicians. People just simply not wanting this, wanting to push this away and wanting it to not be here, feeling trapped, like they don't have any choices. A huge burden causing exhaustion, a loss of pleasure from work, pressure to do more, feeling not productive enough, feeling like we're not doing enough, some guilt at our own kind of privilege at times, or again, not doing enough, both from a work perspective and family perspective. Grief at kind of what it was like prior to the pandemic, both personally and in the workplace. Loss of rituals. So, the grief at sort of not being able to celebrate how we used to celebrate, or when people have died, or when there's been big events in people's families, really a grief at not being able to work through that the way we normally would. A lot of feelings of isolation, disconnection, people feeling sacrificed, and then a loss of faith in leadership, both political and professional leadership, and then a loss of faith in teams because of the impact it's had on teams. And I'll talk a little bit more about the impact on teams moving forward. So these are some of the local themes. I think that some of this might come out in Margaret's talk as well. So I won't get too deep into it, but I've tried to bold the ones that I think are most relevant to physicians. So the anxiety, the irritability, and then the stress of the COVID stress on top of pre-existing burnout. As I've talked about, caring for the unvaccinated has been a big problem, and most recently, and the compassion fatigue around that, and then staff shortages, which are ongoing and kind of projected to get worse. And so, every time I do this talk, I wonder about whether I should bring up SARS, because it feels even less relevant or more of a blip with the duration of it. But I do think it's quite relevant in that we have some good teaching from it about the lasting distress. So, the impact at the time was similar to what we're seeing now, somewhere between sort of 60 and 90% of healthcare workers having difficulty. But the long-term impact, I think, is really relevant. So about 2 years after the pandemic, we're still seeing lasting distress in healthcare workers, 30 to 50% experiencing difficulties with anxiety, depression, burnout, and maladaptive coping. And we saw elevated rates of burnout, as I said, increased substance use, absenteeism, decreased face-to-face time with patients. That's a kind of a marker for compassion fatigue. As you're feeling more overwhelmed and as you're feeling that hopelessness, and the empathy starts to fade as compassion fatigue progresses, there's a tendency towards not wanting to see patients in person as much. As a very normal way to manage that. But that's a marker that even 2 years post the SARS pandemic, there was less face-to-face contacts between healthcare workers and patients. So it just shows you about the lasting distress. Luckily, there wasn't an increase in diagnosable illness. Most of it was subsyndromal stress, but that does not make it any less distressing. And the impact is still great. And the other thing that we saw with SARS is 2 years out, there was still an impact on healthcare teams. So the bottom line is, any way you cut it, we can't ignore the psychological impact on providers. And I have a picture of these kind of superheroes, because I think even some of us that are kind of sort of super docs and sort of don't necessarily look at this as much, and it's hard to kind of to look at the impact of this. It's really difficult to ignore it in this instance. So now I'll look a little bit at the impact on healthcare teams, healthcare leaders, teams, and the system. So some of the challenges for leaders are similar to the individual ones I've just described. Some of them are slightly different. Caring for staff has been difficult. Leaders express difficulty in kind of trying to keep staff motivated, trying to shelter staff from some of the stress, dealing with layoffs, dealing with kind of equity and fairness, and the issues around decision-making in that area. Decision-making in general has been difficult because of mixed and conflicting messaging, sometimes not enough messaging, uncertainty. Sometimes leaders have expressed difficulty around being asked to make decisions that maybe weren't in line with their own values. Sometimes decisions are made by non-clinicians, and that sort of felt in contrast to what their feelings about the next steps might be. And then feeling very caught in the middle. And then the team dynamics I'm going to get into next. So this was very difficult for leaders, but also team members themselves. So what we know based on the data from SARS and also from local and national qualitative reporting is that there's huge impact on the healthcare team function as a result of the stress of the pandemic. Loss of group cohesion, so fragmentation, so the group feeling kind of fragmented, and also polarization, so not just fragmented, but actually taking opposite camps. Teams feeling divided is another way to say that. Team member loss, right? So there's been so much change on teams, demoralization, team members feeling neglected, in harm's way, sacrificed and demeaned. And when those things happen, what we see is that people aren't at their best, right? So when you're not at your best, sometimes you move to what we call these regressive defenses. Sorry to be so Freudian here, but to move back to kind of not managing our team dynamics and our challenges in the way that we might when we are at our best. So a lot of blaming, projection, taking our own feelings and putting them on other people, externalizing, not sort of taking those feelings as our own. And then a lot of difficulty with dependency. Also, leaders have expressed that some of their team members are needing a lot more kind of encouragement or handholding, if you will, than they might have needed when they were at their best. So these are all kind of things that kind of lead to team difficulties and dysfunction. People are easily inflamed, and I like this term emotional contagion. So there's the contagion of the virus, but there's emotional contagion as well, that when some people on the team are feeling overwhelmed, irritable, that they can't cope, that can spread very quickly within a team, and it behooves leaders to see that and try to mitigate it. Challenging, but certainly something that could help with team dynamics. And then a loss of team culture and difficulty maintaining team culture. Some of the things we do to maintain team culture, we need to be able to connect, be in the same room, to be able to socially connect, and a lot of that's been lost. So why is this important? Well, the impact of individual distress is huge. It has an impact on healthcare teams. It has and culture. It leads to absenteeism and presenteeism, which is attending to work, but not providing the same level of work that you normally would. And there's been a mass exodus. Many people have left the profession as a result of burnout, has an impact on the healthcare system. And then ultimately that has an impact on patients and communities, right? The diagram on the left, I know it's quite small, but it basically shows the patients in the middle, and the care team is what's holding them. The system is outside that. If you take the care team out, there is no care for patients and communities. So I just want to look at resilience now and kind of thinking about why this is so important to not only you as individuals, your teams, the health system, and the communities and the patients we serve. We want to look at how can we bolster resilience. So I'm going to look at it from a sort of individual functional domains, and then also looking at what are some environmental aspects that might help better support physician well-being. So through the course of the pandemic, I'm sure you've heard the term resilience 1,000 times and have already come up with your own definition. So apologies. This is the one I've been using for about a decade. I like it because it's simple. So it's a phenomenon or process reflecting relatively positive adaptation despite experiences of significant adversity or trauma. So basically, when the adversity or the trauma comes, we don't just bounce back, we bounce back stronger. That's sort of how I think of resilience. Again, quite a simple model, but I like it for its simplicity. So basically it's an interplay. It's an interplay between the adversity, one's individual resources, and the environment and social conditions. So we've already talked about the adversity here, sort of went through what the adversity has been. And for you, there's many more components to that, but just to think about what the adversity is and how it interplays with the other two. As you can see from the model, there's overlap, right? So things like social isolation would fit nicely in the middle of this Venn diagram. It's not all divided, but it is, I think it's helpful to think of the three different aspects. So individual resources, this is a person's kind of internal capacity to manage the adversity. It's based on distress tolerance, a sense of control, boundary setting, emotional literacy, capacity to use one's emotions effectively, self-compassion, resiliency in the past, and sometimes one's spiritual beliefs or practices can help with their individual resources. Mullen Lesh also talks about individual capacity being bolstered by finding meaning, sort of returning back to the meaning that we have for the tasks that we do, both personally and professionally, and then the degree that one engages in self-care. This is from this is Mamta Gautam's work. She's sort of the doctor's doctor, if some of you know her. So she uses the 5 C's of resilience when we think about individual resources. So control. So I think the number one cause of stress is a loss of control. So when we feel out of control, then it's more difficult to kind of manage with our adversity. And the only way to increase one's sense of control is through boundary setting. How much do we allow ourselves to engage with the adversity? Some of us have more control than others based on our professions, based on our family lives, etc. Our commitment, that's looking at the why of our profession. So finding meaning again. Why did we choose to be in this line of work? And it's hard when it's very stressful to recall the privilege of a job like ours that allows us to make a difference. Trying to regain this perspective can be very powerful in bolstering our resilience. Connection, I'll talk about in a moment. Calmness is about kind of emotion and emotion regulation, and as well as our sort of capacity to bolster that, and then care for self. So I use this acronym with my patients, but I think it's really relevant with all the physicians I work with as well. So these are the kind of evidence-based strategies for self-care that bolster resilience: nutrition, exercise, sleep, time for self to do something pleasurable and supports. And then for physicians specifically, I like to add in self-compassion and the shedding of guilt, shame, and over-responsibility. These are just some domains of resilience that can be measured. And if you want to work to bolster your resilience, these are domains that you can focus on and measure your growth in them. So self-compassion, affect, perception and harnessing, relational capacity, assertiveness, control, distress, and problem solving. So we talked about the adversity and then individual resources. And now I'm going to go on to the environment and social conditions. So social integration is one of our chief protective resources for battling the pandemic. Investing in our networks and our environment will bolster our resilience. Our relationships, essentially, in my view, are everything. I sort of broke down the relationships into 4 components. There's family relationships, friendships, spiritual, recreational communities. You might put neighbors in there, or other.
Sabina just froze for me. Did she freeze for the rest of you? Let's just give her a minute to see if her internet recovers. Welcome to the world of Zoom. No.
Bright new world.
Yeah. She may be permanently frozen. We'll just give her another 10 seconds or so, and then I don't know, Margaret.
Sure, we could.
Yeah, I don't know if I can. I wonder how we unshare her screen.
That's a good question.
I can do it from here. So we'll give her another. There we go. Oh, she disappeared. So I think, Margaret, why don't you just fire up, and then if she rejoins, we can join back at hers a bit later.
Okie. Sounds good.
Thank you.
Welcome. I had to restart my computer too because I froze, so I'm going to now have to open my talk. Sorry about that, everybody. Here we go. Which screen do you see? Do you see the presenter view, or do you see all this?
I see the presenter view right now.
I can swap screens. 1 second. How's that? Better?
Better.
Awesome. Okay. So I want to start by thanking Mark and the Department of Medicine for this invitation. And what I'd really like to do in this talk is build on what Sabina's talked to us about already, about self-compassion, about guilt and shame, and some of the difficulties that healthcare providers and physicians are facing right now throughout the pandemic. I'm going to also address some of the barriers to reducing that guilt and shame, and also some of, hi, Sabina, hi. We'll come back.
Apologies. Okay. I'll jump in.
No problem at all. And finally, I'm going to talk about some work that we've done here at McMaster to really understand the experiences of healthcare workers throughout the pandemic. So, as Mark had mentioned, I'm just going to make my disclosures now. So I'm a professor and the Associate Chair of Research in the Department of Psychiatry. We're very fortunate to be supported by many different grants and donations. Very grateful for that support. I want to start by telling a bit of a story, and that when this pandemic started, I would say I was very much one of those healthcare workers who were quite afraid of COVID-19 and what might happen. And in the end, I ended up being deployed onto the ICU units and the COVID units to provide mental health supports. And during that time, I think I had an opportunity to learn a lot, and it was very much a privilege and continues to be a privilege to sit there with ICU staff, with the emergency room staff on the COVID units and to provide supports. And in terms of a clinical pearl, perhaps around that, one thing I would say is that going into those units, I think it makes sense for the healthcare provider, the mental health care supports to be on the units. The initial thought was that I would be somewhere in the hospital and people would come to me, but what seemed to work out best was having supports right on the unit for staff. And so in one instance, I spent 36 hours in the storage closet on a COVID unit because that was where nurses and physicians and staff were coming to change their masks. And so at that time, they could talk to me, get some quick support, and move out. So just as a lesson around the provision of mental health supports during the pandemic, I would say that's been one important lesson that we've learned from the work that we've been doing. So I want to start with just a couple of comments about the pandemic. Certainly we know this is an unprecedented situation and that no one can fully prepare for a pandemic. And, as this situation has evolved, a lot of the work that we've done around mental health supports has been helping people perhaps to see one another's perspectives. It's very difficult when you sit in the middle in a middle management role, when you're a frontline person on the ground, and then when you're in a leadership position. And sometimes it's difficult for us to see one another's perspectives. And that's understandable given the situation as it unfolds. I think we also thought initially when the pandemic unfolded that this would be a sprint, and it's turned out to be a marathon with a lot of different sprints in it. And so how do we preserve resources and coping across the course of the pandemic? Certainly one spirit that we try to embrace is that we're all in this together and we're all learning together. This has been a very long and difficult process. And how can we bolster and support one another throughout this? In most cases, there are no right or wrong answers, and we try to take that perspective that everyone is trying their best. So as we all know, our world really shifted throughout the pandemic, and it seemed like overnight our mandates, our expectations, and our roles as healthcare providers shifted overnight. And as I go into these groups and into these settings, people often say they've lost a sense of the future, that there's a great deal of uncertainty about how this will unfold. It's almost turned in many ways into a sense of timelessness in terms of when will this end? Can I imagine my future? How will this unfold? And maybe we're starting to get some more answers about that, but I think that sense still remains. And at the same time, healthcare workers have been faced with very difficult, what I would characterize as morally challenging situation throughout the pandemic. I just want to give a few examples before moving on to explain this a bit more. So certainly we've been interviewing healthcare workers across the country. So we have a multidisciplinary sample across the healthcare profession. So we're not limited or restricted to physicians or nurses, but include RTs, occupational therapists, environmental services, all those who provide support within a hospital environment. And what we hear about often is some guilt and shame that healthcare workers experience around, for example, watching patients die alone. This has been difficult in that in healthcare, often that period of death is a sacred time where families are typically present with the patient. But now healthcare workers are taking on that role, and that can be difficult and challenging. And as the pandemic unfolds, also we see that compassion fatigue setting in as well. We also hear from patients that are from healthcare providers that they're often asked to provide care that, for example, the patient may not want, but the family is requesting, or they're providing care which they know to be futile. And certainly I hear that repeatedly on the ICU units, that many times families understandably are holding on to hope for their family member and are requesting all possible measures be made. And in many instances, healthcare workers are put in a position where they're delivering care that can be invasive and painful, but that they are required to provide. And that takes a toll as well, I think, both from a sense of one's well-being, guilt and shame, and also that overall mental well-being. So I have been in family rooms and storage closets again on these units where people are crying and saying, I really feel that the care that I'm providing is torture, and they just break down. Another thing that I think has come up repeatedly throughout the pandemic, and even more so now as we're faced with caring for unvaccinated individuals, is the sense that healthcare workers are risking their own lives. And I'm here to make sure you have food, supplies, healthcare, and you can't be bothered to follow the guidelines. So for example, having a vaccine, which is one way of preventing serious illness, hopefully, with COVID-19. And when we look in our ICU settings right now, certainly, and I would say the situation is continuously changing, and we really need to be abreast of what's happening in the moment. But when we look within our ICU units now, we see many of the beds occupied by individuals who are unvaccinated. And in many cases, which has taken a particular toll, has been families. So entire families who are on the unit. And in many cases, most of those family members lose their lives. And that's tremendously difficult for healthcare workers, both looking at this hopefully preventable illness, along with the anger about how did this happen? And particularly when it's been, in some cases, it has been the children of parents who are unvaccinated, younger adults who may, for example, may suffer mental health conditions or may suffer intellectual limitations where they have not been vaccinated and have lost their lives. And that's taken a tremendous toll, again, on healthcare workers. So as Mark had mentioned, I do a lot of work with the military and with the first responder community. And a lot of what we talk about is moral injury. And really what moral injury is a concept that oftentimes we may be asked to do things, we have to do things that violate our own moral, our ethical values, or we may feel that a person who has a duty or responsibility to care has failed to meet that level of care. And I think Romeo Dallaire described this most eloquently when he came home from Rwanda. And he talked about during his command of the UN forces in Rwanda, he was ordered to stand down by the United Nations and witness the slaughter of the Tutsis. And so as he watched that and his troops watched that, he felt both that this was a morally situation where they needed to intervene. He also felt betrayed by the United Nations and that they had a duty and responsibility to care for the well-being of those individuals, but also for the military members on the ground. And Lieutenant General Dallaire, in fact, bravely defied the orders of the United Nations and did intervene during this situation. But when he came home, if you speak to him, he will say it's the moral injury. It's the moral injury that drives me. And that is really the burden he carries, essentially, we would say a bruise upon his soul. And this is where we have done work again with military members. And here we're asking a veteran, what would it feel like if people were to see inside of you? And the veteran says, it feels really scary. I feel like they're going to see a kind of stain on my soul. I feel a sense of shame about being in the situation in Vietnam. And I also feel shame about some of the things that I witnessed and didn't do anything about. Case in point, watching idly while they threw a grenade in a hole with a guy and knowing full well what the outcome was. Now, this is a very extreme example, but it does illustrate the difficulties that arise from this. But I think what's most interesting in some ways is what he says next. And he says, if somebody found out about me, they might run. Previously, I'd been in a PTSD group, and there was one of the other guys in the group. And he said when he looked into the eyes of a person that hadn't been in Vietnam, it was kind of like looking into the eyes of a baby. They were just that innocent. And I had that same experience. Part of me wishes that I could get that innocence back. That's something I wish very often. And this is what we hear from healthcare workers right now, in that you can say, I will go into these units and say, I understand and I appreciate that as a healthcare worker, you're living in a completely different world than someone who is not a healthcare worker, who is a civilian right now. I think that's very true. What we're seeing, what we're doing, what the consequences of the pandemic that we're seeing as healthcare workers are very different than what people see on the civilian side. And it's often very difficult to come home and talk about this to people where we worry about harming them by telling the stories, and where we fear they may not understand our experiences. And so I think this quote very eloquently captures that experience, which we can apply to healthcare. And so what I would argue here is that moral injury extends to the healthcare community. I would also say that this existed prior to the pandemic. This is not just a situation that's arising now, but one that has been exacerbated by the pandemic itself. And so this is an important concept because we know there are many different mental health impacts of moral injury. I won't go through them all, but certainly we know that the presence of moral injury is associated with elevated rates of anxiety, of PTSD, depression, suicidality, increased substance use, relationship problems, loss of trust. It really has a broad range of implications. And you can see through that quote in these stories, in a way, how those may unfold, that symptomatic presentation associated with the onset of moral injury. But I just want to say one thing again around our clinical understanding of what's happening right now. It's important to remember that as we enter into the pandemic, we all come with our unique histories and unique experiences. So as an example, many people may have suffered from childhood adversity or childhood neglect, and that will impact how they interpret the current situation. We know in the military and among the first responder communities, the rates of childhood abuse and neglect are about 2 times higher than they are in the general population. I can't speculate on that in the healthcare population, but I just think it's important to remember that many people have a prior history of mental illness. They may have a history of childhood abuse and neglect. And some of this will influence responses. And so it's really important when we think about how people are responding to the pandemic to remember that we can't assume the response. And what we hear oftentimes right now from individuals who have experienced trauma prior to the pandemic, they may say, this is everything that I ever expected. Others now know what I live through every day, and I am fine. And so important to remember when we have this lens of mental health and mental health care, and caring for ourselves as well, to remember that not all responses are the same. We're all unique individuals with unique experiences, and there will be a broad range of how people respond. And so to give you a sense of some of the work that we're doing here at McMaster, we now have an ongoing national multidisciplinary sample of healthcare workers. This is about to date 400 healthcare workers across the country who have responded. And what we find in this survey, we find that 1 in 4 reach criteria for a probable diagnosis of PTSD. 4 in 10 report extremely severe symptoms of depression. And it's about close to 8 in 10 report at least moderate symptoms of depression. We see here that 7 in 10 healthcare workers report extremely severe symptoms of anxiety, and close to 9 in 10 report at least moderate symptoms of anxiety. When we saw these numbers, we wondered, do we have a bias in our response? Who's responding to this? Is it those individuals who are most ill? But I had the privilege of meeting this week with both the Canadian Medical Association and the Canadian Federation of Nursing Unions. And what I can tell you is that in the CFNU, they have almost identical numbers when they survey their own members. In fact, Carol Reichard, who's the president, said, we get 77% for depression symptoms, which just lines up beautifully the convergence. And so I think we really do need to pay attention to these numbers and not see them as inflated, but rather giving us a sense at least of what some of this looks like on the ground. What's very interesting is that I would say that having a response to an ethically challenging situation, to experience some level of moral distress, is normative. We certainly know that. For some people, this will extend to the development of a moral injury. For others, it may remain within that realm of moral distress. But when we think about right now, some of the challenges facing us in healthcare systems, I would say one of the biggest ones is the scarcity of human resources. And I think in many situations, I sit, for example, on a hospital board, and we're teetering on the brink, I would say, on the brink of disaster, where if we lose any more of our nursing staff, our healthcare staff, then that imperils our surgical capacity. It imperils our capacity to run the ER, to run the ICU. And this is, I think, something that we see across healthcare settings now in Canada. And so what are some of the reasons driving why healthcare workers may be leaving their professions? Well, one thing we know is that we know that in the past, certainly wasn't the case that people weren't not considering this before. And we surveyed these 400 healthcare workers, and we asked how many had considered leaving their profession in the past. And about 60% said, yes, I've considered that. And we asked why. And they said, well, for those who did complete and left, who left a position or left their job, but 1 in 4 attributed that to the presence of moral distress around what they were seeing and what they were doing within the healthcare arena. When we look now, we find in our sample, and this is consistent with what other surveys are finding, about 1 in 4 healthcare workers are currently considering leaving their profession. And we see that now, for example, in our surgical recovery, where in many settings, we're not able to ramp up to 100% capacity because we don't have the staff to do that. And when we're now in a situation where 1 in 4 are considering leaving, this points strongly towards difficulties we may face in the future as well. I just want to highlight how some of that moral distress, giving name to that moral distress, think about how we address moral injury, which is something I think we should come back and talk about, how this may help to not only help the individual, but help the system as well. So in terms of our, it's just interestingly, if we look here, often what we found for those who were considering leaving, we see it was more common among women, more common in hospitals, more common on the COVID-19 units, for those who are a slightly younger age and those who have been practicing for fewer than 10 years. I think that's just interesting to think about characterizing those who are making these sort of decisions right now. So I want to just end on this note in terms of the qualitative interviews we've been conducting. Just want to summarize some of the experiences that people have described. And it's really important that we have cultural competency in terms of what our healthcare workers facing right now. We hear often that when we go in as mental health care professionals, for example, oftentimes in the military and for first responders, what we hear is that the clinicians break down crying when they hear the stories. They can't handle them, and they're not in a position to provide care. So for anyone who's in a leadership position, for anyone who's providing care, who's trying to help their colleagues, I think it's really important to understand what people are experiencing. And when we asked these healthcare workers, what would you like most? What can we do for you? They said, I want you to know my story. I want to know the story. I want my leaders to know. I want people to understand. And so here are just a few of the things that they summarize. These are the top 10 stressors, and we release these ahead of publication. We've released these really nationally because we feel it's important that people know what's happening on the ground. And so they talk about, again, that repeated exposure to patients' prolonged suffering from COVID-19 and the provision of futile care, the exposure to an increased number of deaths, including younger, unvaccinated, and otherwise healthy individuals. They talk a lot about patients dying alone without family, taking on the role of the family at the end of life, and not having the time to process or grieve the deaths. And I hear that exhaustion and burnout is something I hear all the time, but people also feel non-deserving of time off and rest. They talk about how if they're not there with their team, they're letting the team down. And so there's a lot of guilt and shame around that as well. People, of course, express that fear of transmission to self, but even more so to their family members and others. We're also seeing, and I think this is going to resonate in particular, perhaps among members who are here today, the disruptions in family life that we're seeing. These are due to increased work hours and in the beginning of the pandemic, living apart for safety. I have healthcare workers who say to me, I can go home and say one sentence to my family or one word in some cases. I don't have the energy left for this. I can't parent. My partner has had to take over. This is causing a lot of stress within the family. There has been some concerns around employer support, what some people perceive to be the inequitable mandatory deployment to COVID units. There's also been a lot of stress, of course, in enforcing the no visitor policies that we need to have in many cases or have had to have. And then, of course, as we talked about earlier, that concern about traumatizing others who are not healthcare workers by talking about their experiences and feeling that they're living in a different world apart from non-healthcare workers and not feeling understood. And then finally, on a very pragmatic level, the loss of usual coping strategies, including access to gyms, socializing with peers and family members. And we always say mental health isn't necessarily magic, right? If you think back to what's helped you in the past when you've been in a stressful situation, has that been exercise? Has that been reaching out to a friend? Has that been having a hot cup of tea at the end of the day? Thinking back to what's helped us in the past can often be very helpful in guiding as we go forward with the current challenges we face. So I'll end there just by saying thank you to our team and turning it back over. Thank you.
Thanks very much. Dr. Riddell, just we have about 15 minutes left in round, so we just have to watch the clock. So thanks very much.
I'm just going to share my screen.
Margaret, no, yeah, can you, good, okay, thank you.
Is it showing the presenter view or the slide deck?
You are just seeing the slide right now.
Okay, perfect. All right, so thanks everyone. I'm Tara Riddell, and I thought I'd end by just reviewing some of the resident experiences, being not too far out from residency myself.
So Dr. Riddell, sorry, you're in the slide mode, not in the presenting mode.
Oh, okay, 1 second. It's having a little bit of, I seem to have lost my my mouse, or it's frozen a little bit on my end.
We can see the slides like that. I don't know if you want to try it. Can you advance?
I'm trying, but my mouse doesn't seem to, it seems to be frozen.
Okay, you know what? Maybe just turn it. Oh, wait a second, where something is happening. Now we can see a portion of it. I would say, can you, I'll stop your sharing.
Perfect, thank you.
And then see if that resets things and see if you can share again.
Still showing as my, that I'm in presenting mode. It hasn't seemed to close it on my end.
Oh,
Oh, I have, my mouse is back now. Let's see.
welcome to Zoom.
The joys, even 18 months in, we're still experiencing some of the same issues. All right, let's see. All right, let me try this again.
We are not seeing anything. We're seeing you. Oh, there we go. Ha!
Okay.
We got a black box, but it says you started sharing. There we go. Now you're in.
I'm just in the PowerPoint, so I'm going to see from the beginning and see if that works this time.
You've got a little over 10 minutes now, so sorry.
That's okay, no problem. I can breeze through it. Is the slide showing now?
On my screen, you're still in the original mode, but I don't know what others. Margaret, can you see
Yeah, for sure. Yeah, I still see the
toolbar?
yeah. Sorry, everybody. Sorry.
Well, that's okay. Can you advance the slides right now, even in that mode?
Let's see. Does it advance for everyone else or just for me?
Just for you.
Yeah, there's a suggestion. Choose a different screen share. May have multiple screens.
Let's see. How about now?
Nothing changed.
These are the worst moments, Tara. I know.
Yeah, I know. I've usually been lucked out in the past. It's been
You advanced anyway,
Oh,
so
okay.
we can now see your mouse. So maybe just try and don't touch anything. Just maybe go from there. See if you can.
We'll see if that works. All right. So do you see the objective screen at the moment?
Yes.
Okay. All right. So I'll just breeze over that since we're short on time, and as well just to say that I have no disclosures. So before we talk about the impact of the pandemic on residents, I think it's important to remember that residents are vulnerable at baseline. We know from the existing literature that students often enter their medical careers with better health and lower rates of burnout, but this soon changes over the course of their training. And residency often marks the time where we see peaks in burnout rates. And this even sees pre-COVID of rates upwards of 60% or even higher, depending on the study that you look at. We also know that this can be due to a variety of factors, including the dual roles that residents play, both as a learner as well as a practicing physician. We see also that there are several factors, even at baseline, that can impact resident stress and burnout, those including workload, a lack of control, exposure to trauma in the workplace, mistreatment, inadequate support, as well as carrying significant debt too. Looking at this list of factors, we can likely imagine that these have probably been exacerbated in many ways by the pandemic, leading to greater negative impacts on their well-being. It's no surprise then that the literature confirms our suspicion about this. This is one of the larger studies done to date by Zarub and colleagues of over 1,100 residents across the US. And they found that on the whole, residents' wellness and their resilience had been reduced. The authors of the study also found that amongst different specialties, internal medicine residents tended to fare the worst, which may in part be due to an association the authors also found between declining wellness and increasing contact with COVID positive patients, as well as higher local infection rates. Outside of some of the chronic pre-existing stressors we already touched on, they also identified 3 stressors that may also be related to the low rates of wellness, those being more around health and safety, either concerns about one's own risk, the risk of infecting others, as well as having inadequate resources, largely the lack of access to PPE. When we explore the impacts of the pandemic further, studies have confirmed that there has been a significant toll on residents' mental health. We know in the last 18 months, the majority of residents have experienced increased stress, with 2 out of 3 residents experiencing burnout, 1 in 2 residents experiencing anxiety, 1 in 3 residents experiencing mild to moderate depression, and more concerningly, 1 in 5 residents experiencing thoughts of suicide, self-harm, or even resignation from their roles. When we think about some of the potential contributing factors leading to these mental health impacts, we can first reflect on those that may be related to the clinical work environment in residents' initial role as being a practicing physician. Some of these stressors may be similar to those that have already been mentioned and that affect other providers, such as increased demands and workload, concerns around safe working conditions, access to PPE, and adequate communication from the organization. However, studies have also suggested that residents have perceived a greater exposure to COVID compared to their faculty colleagues, as well as there's also been challenges encountered when rotations have changed or when they face the very real threat of redeployment. In considering residents' other role as a learner and the fact that one's training in medicine is largely experiential, we also know that the pandemic has potential to cause significant disruption to medical training, which can also contribute to increased stress. And unsurprisingly, when surveying residents, majority, upwards of 70%, agree that the pandemic has had a negative impact on training, with the frontline specialties, including internal medicine, being most significantly impacted. In terms of some of the specifics around stressors in the educational environment, we know that everyone has had to pivot to virtual learning, which clearly still there's some challenges in navigating that. And we also don't truly know the effectiveness of virtual platforms. These sessions have also reduced connection with one another and blurred the lines that much further between work and home. Residents' clinical exposures have changed, which if prolonged may impact their ability to manage a broad range of pathology. It's also reduced opportunity for skills-based learning and procedures and reduced direct teaching. Many residents have experienced canceled rotations, electives, conferences, which can impair their professional development and acquisition of needed competencies. And certainly many of us here are aware of the impacts on assessment and evaluation with cancellation and delays in examination, which also puts risk to the transition to practice as well. As we speak to how medical education has been affected during this time, I think we'd be remiss if we didn't also pause to consider the perspective of faculty educators as well. As COVID has been unprecedented and we're all learning together in real time, some faculty have suggested that they felt that loss of that expert identity as they're trying to keep and taught and learn on the go. We also know that faculty, has been highlighted here, have increased workloads and they may have less time to dedicate to teaching, even though teaching demands are greater as residents try to prepare for redeployment while also trying to maintain their skills and knowledge. Faculty have also had to experience the growing pains around shifting to e-learning and also are struggling with their own well-being, which makes it difficult to support residents too. Just one approach to thinking about how we may enact change and support residents would be using the Stanford WellMD model. This looks at 3 core themes: culture, wellness, practice efficiency, and personal resilience. And this shares some similarities with the model Dr. Nagpal also reviewed. Culture, wellness, and efficiency of practice tend to fall more under the purview of leaders and organizations, but I would also argue that there's some support they can provide for personal resilience, including accessing supports. See one example in practice, UBC's general surgery program published their findings of what they did to support residents using this model during the pandemic. With efficiency of practice, they focused really on enhancing communication with residents, as well as setting protocols to limit exposure to COVID positive patients. with regards to their culture of wellness. They almost made it a mandate that if you experienced any symptoms of burnout, you were to stay home, similar to a physical illness, and created reserve lists of residents to fill in for those who were absent either for physical health, quarantining, or for mental health reasons as well. And then for personal resilience, they had a wellness group that helped to provide meals for residents in hospital. They had mandated check-ins to provide some social and emotional support as well, and also tried to provide a sense of control by giving residents the opportunity and choice whether they wish to be considered for redeployment. Similar for faculty, we can also use that same model, thinking about things like faculty peer support. In Canada, a number of ENT programs have joined forces to set up a regional academic half day to allow sharing of educational resources to reduce some of the burden in that sense. And then also as a reminder for faculty of the need to take care of oneself before you can take care of others, that similar motto of putting on our mask first before we can do so and help others do the same. This is a final, I'm going to skip that slide, final recommendation just around last tips that came from two really good articles I would recommend for faculty and programs, just reiterating that learner well-being is a priority because we know this is a group that's at increased risk. That social support and connection is really critical. And there's opportunities as we work together between residents and faculty to really just reflect on what it is we're experiencing, to validate the emotional experience, and also to share together in our struggles and our strengths. And reviewing that help seeking is a strength and is actually career enhancing in the long term. And that it's really important we advocate for needs at all levels and to ensure that our learners, our faculty, and other healthcare providers are all being supported. So with that, I will wrap up with a few minutes to spare, but just a reminder of some formal supports available for both residents and practicing physicians, both locally and nationally as well.
Thanks very much, and apologies for the time pressure at the end there, and sorry to Dr. Nagpal for not being able to do the technical parts. I'm not sure, that was a bit weird. We generally don't have technical problems, but such is the life of Zoom. And so I'd like to thank the three of you. There's one question in the chat, which I'm going to expand upon. Greg Kernew asked it, but I'm going to change it a little bit. So one of the stressors in medicine that is very interesting for me to see is that we have groups of people where one person has been in the hospital, every single day except for the weekends or a few days off for the last 19 months. And we have people in exactly the same division who have not been seen in the hospital for 19 months, have been doing clinics exclusively from their living room, have done very little resident interaction. And this is probably someone, I think a couple of you alluded to the idea of splitting within the team, that this is a real stressor for a lot of people where they don't feel that they feel that they have committed a lot more to this than some of their colleagues have. What are your thoughts on that? And what's the strategy to try to overcome that?
Would you like me to comment, or do you want to comment, Sabina?
Go ahead. Oh, you can go first, Margaret, and I'll add in. Go ahead.
Yeah, it's interesting, Mark, because I found a lot of the work I'm doing now is not just around mental health support for individuals, but engaging in reconciliations between different levels and different parts of the system. And so I think it's really important to come together in a way where you express how you feel, right? Like just say, this has been the impact on me of this. This is how it's made me feel. This is what I would prefer happen instead. And then also giving the other individual, though, who you feel aggrieved by, the opportunity to also give their perspective too. So to say, I have had, fear for my family, I have whatever it may be, but the opportunity to open up that conversation, not only to talk about how you feel, but the hurt. Because I think oftentimes anger stems a lot from hurt, right? So it's often a secondary emotion. So do you feel hurt and abandoned by individuals who you feel should have been there for you, for example, right? And what has the impact of that been as well? So the impact has been on me and my family because I haven't been able to spend time with my family as a result of always being there. I think opening up that conversation, trying to see each other's perspectives is the only way to move forward, in my view, right? We could ignore it and do nothing, but I think having that open conversation to discuss it and be open about the feelings and the impact can be helpful. It's good to have it mediated, though. I do essentially mediation sometimes in the middle of this, and to have that mediator there, I think is important. It really does help. That's my view, right? If it's just an open free-for-all, it doesn't work.
Yeah, I'd echo what you said, Margaret. And I think that, given how busy your departments have been, everyone's, but internal medicine's bearing the brunt of a lot that's gone on in the pandemic. Yeah. I can see how these things don't become, the top of the list. And that's completely understandable. And I think because we know of the lasting impact on teams, intervention is really important. And I would support probably third party or kind of a mediator intervention, because I think it is challenging on the inside to do it. I think if it's so obvious on the outside that people are seeing it, then there's probably a lot more to it, right? This is a symptom, if you will, a marker. There's a lot more to it. And what I talked about a little bit about kind of people aren't at their best. When we're not at our best, we have the tendency towards assumptions. So there can be assumptions about why people are doing certain things. And when left unchecked, that breeds a more fragmentation and division on the team. So I think mediated conversations about how things are going within particular teams, and as Margaret described, giving people an opportunity to provide their perspective allows for the team to reunite. Some of this stuff might have happened naturally in the past when there were social places for people just to connect and have positive connection. Now, because most of our connections are essential or under the context of stress, there is really not a lot of opportunity to smooth differences out in a more natural way. And so I think for a department like yours, if resources allowed, I think it would be helpful to have a formal way to work through some of these difficulties.
Yeah, thanks very much. One thing, I don't think other departments have done this yet, but last week we had our Departments of Word dinner in Laguna Station. We had 60 people there, and it was a lot of fun. And I think people derive a lot of value from that. I'm encouraging my divisions to have face-to-face meetings. Like if we have to rent Laguna Station to put 12 people in it, we'll do that. I think that realizing that people are three-dimensional is really important, and the face-to-face interaction, perhaps mediated, may be a great way forward, because some of this has been exacerbated by Zoom, because it's a lot easier to ignore people on Zoom than it is in person. We should end there because we are a little bit over. I'd like to just thank all three of you. Dr. Riddell, I asked Leslie Martin, who's my program director, to get in touch with you. You may have seen that in the email already, because I think you would have a great conversation with her about some communication strategies we need to develop for our resident staff, who have been at the front line of this thing for the whole 18 months and seeing and admitting essentially every patient with COVID. So they've borne a lot of the brunt of this. I'd like to thank all three of you. We'll look forward to more communications in the future. Thanks to the Department of Psychiatry and Neurobehavioral. I don't know the actual name, but Psychiatry is what I call it. You've been a great help for us. I called Nick numerous times for faculty members needing direct support, and Nick has been very, very good at hooking people up with some very specific support, which we appreciate deeply. It's been very important for many people in the department to be able to access those kind of resources quickly. And if any of you have provided that support, I know Margaret has, I'd like to thank you personally. So thanks very much. Appreciate your time. And for the grand rounds people, the hospital rounds will resume next Thursday, and then medical grand rounds for the chairs will be a month from now. Thanks very much.
Thank you.
Thank you.
Ready? Bye.